Welcome, everybody. I'm Enrico Bassi, manager of the Fab Lab OpenDot. I'm very happy to welcome you all to this online event. The title is already a synthesis of what we want to talk about, a distributed answer to the global crisis that we are all facing. So, very briefly, an introduction. This is our Fab Lab. OpenDot is a Fab Lab here in Milan, founded in 2015 by an interaction design studio called with the objective to use technology as a driver for innovations. And since the beginning, we focused a lot on health and care because we thought that digital fabrication could have a huge impact in this area. And what's happening during the last week actually proved that it was the right approach. What we have seen is really impressive. After the outbreak of COVID-19, a lot of people at the beginning, and then groups of makers, and then large communities of makers started to try to figure out how to contribute, how to tackle the crisis, how to help healthcare professionals to protect themselves and not just them. And never before the maker community actually had such an active role globally at the same time, designing, distributing, producing solutions that really were needed by people otherwise exposed to risks that could threaten their life actually. So it's the first time also that the maker community is working that closely in health and care on such a large scale. So to us it was really interesting to see the potential that we thought about for a long time displayed in front of our eyes globally and every day on a larger scale. So it's not just thinking about new things and new prototypes, even if that was a big part of the process. It's also what has been said, filling the gap of the traditional industrial production that couldn't catch up with what was going on and the requests. And it showed that the flexibility of the way makers make things and react immediately, fast, together, organizing themselves in community was the right way to go. The other thing that I think it's fundamental to keep in mind is that everybody worked mainly driven by a common set of values that we all share, and the will to be capable of contributing and helping. So our talk tonight is part of a EU-funded project called Distributed Design that aims to bring together makers and bring them on the market, allows them to actually become a part of the economy and not just cultural or about education and training. Again, we are seeing this happening right now in this specific case. So how the community could work in this direction, how the makers can be effective. It's important to understand that it's not just one point, but it's actually a set of different factors. We decided to select the three that were more impacting to us. And of course, since the beginning, makers worked on developing new ideas, and that's actually still part of what's fundamental to have. We'll see an interview that focuses on how an open source idea could actually spread quickly and reach different nations around the world, a thing that could be impossible for a company to do, for instance. After creating great ideas, we need to know the legal framework in which we move. And in particular, when we talk about health and care, that's a key point. It's a complex sector with a lot of regulations meant to help people and keep them safe. So it's really important to move properly within this context. The third key point that we want to underline and discuss tonight is about the role of communities. So compared to the industrial production and what we're used to, the way the makers and fab labs work is a completely different thing. We are used to work together in networks, organize the effort that we do, and this is completely different from the traditional approach that the company has. So the community is really a key point in this process. To actually bring on the table direct experience on these three key points, we interviewed and invited 3 people from different fields. We have three guests. We interviewed them last week, and we have them here with us today, ready to answer all the questions that will come up during this webinar. So keep your questions for the end. We'll have time to discuss with them, and I would move on with the first interview that it's about the ideas. So we decided that one of the best example was the intubation box. It's a protective gear developed and thought by a doctor in Taiwan, but that became popular thanks to the effort of Benjamin Rhys and Tina Rhys, a couple that from the US to Gedia developed it furthermore. And I let them speak about this project.
I'm Benjamin Rhys. This is my wife, Tina Rhys. I'm a physician. I specialize in emergency medicine.
I'm a designer by training, and right now I do mostly product and project management.
From a medical perspective, from me being just one physician in one's perspective, we're still seeing a lot of cases. Case numbers haven't really gone down or gone up. They stayed pretty steady, at least out in the West where I'm at. At the same time, we've got some states that are opening up and no longer enforcing, the stay-at-home policies, where other states aren't. And then within those states, certain cities are opening and other cities aren't. And so it's been amazing everything being shut and what it's been doing. And in my opinion, medically speaking, it saved countless lives just because of the way that it's allowed the healthcare system in the United States to take the patients as they come and not have them all dumped on them at the same time. This is one of those things that we have no real data on other than what we've been able to scramble together in the last 6 to 7 weeks kind of thing. And sorry, my daughter's pulling cables. And in that amount of time, we have all these projections, all these people looking at this very limited data and trying to make these big decisions. And it's, in my opinion, a big gamble a lot of times. But either way, it's not over yet. We have stabilized in the sense of it feels like, people know how to do this. They know how to navigate the system and the way that infection is happening. But really, a lot of things that have helped with a lot of the other healthcare workers, including myself, is we went into this with a lot of anxiety about the fact that, this is a brand new threat. We're used to all of these other threats that we trained on, that we've learned about. And even in emergency medicine, we kind of act is cow towards the problem. We jump into the room with the person bleeding out. We do all this stuff. And it's part of the fun of being an emergency physician. And rarely do we take a step back and think of our own mortality. And this whole situation has really made us hit the brakes and be like, oh my gosh, is this gonna make me sick? Am I gonna catch this? Am I gonna take this home to my family, my loved ones? Across the board, there was really no preparation and no preparedness when it came to having to all of a sudden, all of your staff needs to be in protective equipment, as opposed to just 1 or 2 of your staff members need to be in protective equipment. And one of those staff members once or twice on a shift, where now everybody that's around these patients, the whole shift between rooms, changing medical protective equipment back and forth, like it's an exponential growth in the need for the numbers of protective equipments. And that just wasn't even remotely available. And so that's part of the reason that there was such a scramble for everything across the PPE spectrum of equipment. One of the things that I was doing as a physician specifically in the emergency department, a lot of times before we decide that somebody is going to need to be put on a ventilator, we have to intubate them. And intubation is the action of basically putting a tube into the trachea, into the airway of the patient, and securing it there so that we can then connect that tube to the ventilator machine. The process of doing that, basically what we call a blade or a scope goes in the mouth of the patient so that you can visualize the airway. And then a tube goes in that has a stylet in it, like a rigid stylet that goes in. So both of these things go into the mouth of the patient. They're sedated, they're laying on their back. And when you visualize the airway, you get that tube into it, you pull that blade out, and then at the same time, you hold the tube in and you pull that stylet out. That activity itself, each time something comes out of the mouth, is taking particles that are, very, very small and aerosolizing them and throwing them up into the air, throwing them right into the face of the physician, throwing them right into the face of the respiratory therapist or the nurses or whoever is assisting, and just bringing it up into the air in that room. And we're already wearing, our glasses, a mask, maybe a face shield kind of thing, but it still doesn't change the fact that we're still just throwing stuff right into our faces. And so early on, we were scrambling with the way to have some sort of barrier. And so we were literally taking clear trash bags and just cutting them in half and just draping them over a patient, and then trying to visualize through a wrinkled trash bag to intubate these patients while still protect ourselves and the rest of the staff around, kind of thing. And I mean, that it worked as well as you can probably imagine it is. It's almost more trouble than it's worth. I was on just an online forum that a lot of emergency physicians use, and everybody was kind of having the same issues where they're like, oh my God, we're using trash bags, or somebody was using just a piece of plastic that somebody was trying to hold over top of them. And kind of out of nowhere, somebody mentioned, oh, hey, there's a physician, Dr. Lai out in Taiwan, who made this real straightforward box that just sits over the head of the patient. Check this out. And I took a look at that, and I was like, this is so straightforward and simple. This is all we need. Just something that we can just put over them. Why didn't I think of that? Why don't we already have this in the medical field? Why is this not already standard of care? It's so straightforward and simple. So it basically, I saw the designs. Within 20 minutes, I was on the phone with a couple different people trying to see who had access to, acrylic and solvents and the ability to, cut them for me and help me get a prototype done. My wife, who sadly ran off, is wrangling our child at the moment, was able to get me in contact with one of the guys that does R&D for her work, which is a mattress company. And I got a hold of him. I sent him the plans. I told him what I wanted to do with them. The original plans was just basically like you've seen, just a box. We ended up looking at it and saying, okay, this was designed in Taiwan, so the body size is going to be significantly smaller. And I originally basically took a cardboard box and cut it out and just taped it together to the size of what the original design was. And I laid down, because I'm a big guy. I'm 6'3", 250 pounds. I'm a big guy. And I laid down on the table, had my wife put it over me. And she's like, you don't fit in this, kind of thing. And so we were like, okay, we got to expand and make it bigger. We made it wider. We took the holes on the end of it for the hands, and we made those, the diameter, we increased that a little bit too, just because, again, I don't have massive forearms, but with the size that it was, trying to have a bit of dexterity in there, I was hitting the sides, and so we increased that. And then the last thing we did was put a lip on the end of it, because as you're aerosolizing particles out of it, they can still hit and kind of flow forwards, and there just wasn't a lip yet, so we just came down a few centimeters and created a lip so that it at least has kind of a catch. And again, none of this was 100%, but it was still way better than nothing. And so with that kind of change in the design, we were able to get a prototype done basically within 24 hours. I took it to work the next day. I had all the other physicians around me, and we put a couple different nurses on the table and used them as as test dummies kind of thing, and they were great sports about it. And we all used our equipment, put our hands in and out, try to just make sure we felt that we could still do what we need to do with this. And we basically, everybody was like, this is perfect, this is what we need to use. And so that kind of solidified it as something that needed to exist as a regular tool in our armament for healthcare kind of thing. Within that first 24 hours, after we had that prototype, and I went to the hospital, tried it out, and I felt safe using it as a physician and that other physicians could use it. We had another buddy who got a website for us, and we put the plans up and just started broadcasting them to as many medical networks as we could kind of find. And within a week's time, we had so many people back and forth saying, we can make this, or hey, what about doing this, or what about doing this to it? What if we switch the material? Hey, I can make it for cheaper, I think, with this material. That we ended up even having to just make a forum on the webpage, because so many people who at one part aren't really working as much right now because so much of the country is on lockdown, who are looking for something to do in general, and then looking for something to do that's going to help. I think we were probably one of the first, if not the first, to market in the sense of taking the design, changing it, putting it on the internet, showing people that it works, having photos up, and other people across the country ran with it. There was another group on the East Coast that 4 or 5 days after us started to GoFundMe, also put up a web page, started taking requests, started putting those boxes out. We were having groups that were emailing us saying, hey, what if you drill another hole on this side so that the respiratory tech can help? Or what if we put a drape over the end of it to create, more sealant? Or what? There was just so many things that were day by day. Every time I would wake up and look in the inbox of my email, there's just 60 to 70, it just growing and growing of all these people like coming up with all these ideas and all these different changes. And by that point, Tina had started answering a lot of those emails and going through a lot of that stuff. And so she actually probably knows about even more of the innovations that people were coming up with, just because I was still working full time in the emergency department. So many people took those designs and just went crazy with them. And that was really all we wanted to happen, was that I did it. I was able to find people within 24 hours that could make the box for me. Like, everybody else should be able to do that and more. And so that was originally what we wanted to have happen. And that's exactly what happened. And so it was great. And we even kind of sent a message to Dr. Lai on Facebook. My wife was able to find him, and she's from Taiwan also, so she speaks Taiwanese, and was able to connect with him and be like, hey, we took your design, we're using it, it's saving lives, we've changed it a little bit, there's hundreds of people using it now. And he was really receptive and really happy about it. And so we felt like we were just doing the right thing. And we realized that it wasn't just going to be us putting the plans out there and then stepping back and returning to our lives. It was going to be all these people asking for us to get boxes to them. We realized, like, we have no way to like, are we going to ask people to pay us and then send them a box? Like, we don't have a company. We don't have anything like that. It's just, you know, the two of us with our full-time jobs and lives trying to sort out what to do. And so, you know, GoFundMe, I'd never even, I think, been on the GoFundMe webpage and so I had to figure out how to create that. And through Tina's network, we were able to have friends help us set that up. I had another buddy that had done fundraising in the past for some projects out in LA, and he was great about jumping on board and just phone calls kind of thing, and reaching out to his network. And so with the GoFundMe and basically social media, which prior to all of this, you could not find me online. I had no social media presence. I didn't want one. I still don't really want one, but they can't change that now, kind of thing. But so I really was not in that world very much. And people were able to just reach out and do that. You know, a couple of the local news stations got wind of what was going on, and they came and interviewed us and put the word out more, and that really helped. It all snowballed into people donating. You know, at the end of the day, the GoFundMe raised $40,000. So as of probably a week ago, just from us, we have gotten over 500 boxes fabricated into hands of other physicians, other CRNAs, people that need them, kind of thing. I know we have outfitted almost every hospital in Arizona, a good portion of California, and then everything else has just been all over the country. And when it comes to this whole project and things like it, nothing has gone through the FDA, where, you know, at least in the States, that's what kind of approves all sort of medical devices, you know. But this is a time of a pandemic, and this is best practices are in mind. And so we're doing the best that we can with what we have. And thankfully, it's better than nothing. And a lot of times in the normal rigmarole of like getting devices into hospitals and doing things, in at least in the United States, like, it's got to go through weeks and weeks of meetings and review boards and all this red tape. And the way that I kind of wanted to circumvent that sort of congestion was I was sending these boxes just directly to other physicians and saying, you put this together at home, here are the instructions, and you take it in. And that's what enabled us to not really fly under the radar, so to say, because we weren't trying to do anything wrong, but we wanted people to be protected, and we wanted it to happen now. And that was the best way to get it to happen. And thankfully, that's worked out. Very, very few of the hospitals did they get any pushback where they're like, oh, has that been approved by ABCDE? You know, because then the physician can come back and say, well, so you want to take away this protective device? You want to make it more exposure to your staff? And that shut down administration in a lot of places very quickly. Thankfully, it's been very obvious that there's been a lot of things that have been made in the last couple months out of sheer necessity and innovation that are saving lives. And how do you argue that not being a good thing? Yes, you know. Take care, everybody, and be safe.
So this interview was amazing to me, to see the passion. But it also underlined an important key factor, that it's the objective is to keep people safe. We have to do it sometimes avoiding the official process to certify and approve some solutions, but never ignoring the rules. So that's why the second interview that we did was actually focused on the legal framework. And in particular, we spoke with Elisabetta Biasin, a legal researcher in KU Leuven. KU Leuven is actually one of the partners for another European project OpenDot is involved in, called Made for You. And the objective of Made for You was to select and document and share open solution for health and care. And of course, one of the key points was how to do it safely. So Elisabetta and her colleagues actually thought through how to explain this legal framework. It is not an easy thing for a maker, and a synthesis of her suggestion is in the next interview.
Thank you, Enrico, and thank you to OpenDot for inviting me here and to talk about this very important issue, in my opinion. And thank you also to all listeners and who is displaying this presentation for their interest in this topic. So my name is Elisabetta Biasin. I'm working at the Karl Leuven Center for IT and IP Law, and the research that I've been carrying out so far is for the careables.org project, which is a Horizon 2020 project that aims at creating an open collaborative platform for open source hardware healthcare solutions. Today, I would like to give, as anticipated, some legal recommendations for makers. So let's navigate the law, and let's start with our 4 recommendations. So our first recommendation is an ethical one. Do no harm and be responsible. Just like everyone else, makers have a duty to refrain from causing harm. Before developing a possible design or application, we think makers should question whether the solution will be the most appropriate for coping with the issue at stake. If the answer is yes, aside from thinking of ways in which this solution could benefit individuals, makers should always anticipate risks and also likely side effects. And also, in my experience, I've received very often questions such as a maker, as a designer, will I be liable? Well, you cannot hide for your actions. If something goes wrong, there is room to be held liable according to the law. So I think that makers should be aware of the degree of responsibility and liability while operating in this context of the pandemic. And degrees of responsibility may vary, especially if you are operating within a professional context and you are replicating a healthcare solution to be used by healthcare professionals, or you're doing it for private purposes. In the first case, it's more likely that the maker's degree of liability might be stricter than in the second case of private purposes, where nonetheless due diligence would be required, of course. Second recommendation, and I would say let's dive now into the nitty-gritty of the problem. I think here we need to focus on medical device and personal protective equipment regulations. In fact, some of the items that makers wish to reproduce might be covered by specific legislation at EU level, national level. Here we are talking about international legislation, European legislation. So I'm trying also to provide very general recommendation, because we don't want to refer just to Italy, but also to a wider context. So items might be covered by specific legislation, such as medical devices law or personal protective equipment laws. In Europe, medical devices are regulated now by the Medical Device Directive, which is implemented by national law in every member state. So every member state has its own law on medical devices. And also personal protective equipment is regulated now by the EU regulation. So this law refers and contain procedures, requirements for manufacturing certain items, and may set strict requirements concerning safety and risk assessment. So, in case a maker creates a healthcare solution, such as face masks, filters, goggles, some kind of face shields, and if it's being reproduced in a business-related context, he should be aware that sector-specific laws may apply and safety measures should be taken into account, like conformity assessment procedures, declaration of conformity, and similar. Some kind of accessories also may fall within the definition of this. For example, 3D printed balls. So this is a bit the theory. I just wanted to pick a couple of examples to give a practical insight. So let's take, for example, surgical masks. Surgical masks are considered medical devices and fall within class 1 risk, which are by law considered as low risk devices. This means that they do not need the notified body assessment to be marketed. Indeed, for example, in the Italian legislative framework, the manufacturer must simply formulate a declaration of conformity and declare compliance with medical device regulation and fulfillment of related administrative procedures. But to give an example of surgical masks, I want to differentiate for other examples that might be similar but which are not, like filtering masks. So we have been hearing in the last days about filtering masks. These are not the same thing as surgical masks. These are filtering masks because, and this new category, for example, in Italy has been introduced by the Italian legislator because there are new laws that derogated a little bit on medical devices, and we will talk about that later. They didn't guarantee sufficiently the continued supply of surgical masks. So for that reason, there were established further measures, and including also the new a new law on filtering masks with new articles on the Cura Italia legal act. So filtering masks are a new type of category. They do not fall within the medical device or personal protective equipment category. So they differ for surgical masks because they are not intended for medical staff or workers, but they are rated for the community. So this is another example where it's really important to understand what is the scope of application of the law, the objective scope. And for example, for surgical masks, then there is a medical device application, and for filtering masks, there is not. And also, I just wanted to briefly mention 3D printed plastic balls used in respiratory ventilators, which is another example. It's really important, and they may qualify also either as accessories of medical devices or their parts and components. And this was made clear by EU level guidance provided by the European Commission in the last days. Going forward, and the third recommendation concerns intellectual property rights. So we decided to have this nice recommendation: keep calm and choose a license. Intellectual property law, what it is? It refers to the creation of the mind, and it regulates inventions, literature and artistic works, designs, symbols, names, and images used in commerce. For makers, these aspects are really important, especially during the design and reproduction phases. I mean, they're always important, but we wanted to stress these two phases in particular. So in the design phase, makers should be aware of the copyright law to their design and other work that they are co-something or remixing. And when they upload a project on a platform, they should decide whether or not to license it. This is really important because in the absence of a license, stricter copyright protection applies by default. So it means that the design that you are going to upload on a platform will be protected more strictly with respect to the cases in which you want to choose a license that allows the remix, the replication, according to certain schemes. So by choosing a license, makers then can decide whether other people can improve their design or freely replicate it. And of course, conversely, when you reproduce an healthcare solution, when a maker wants to reproduce an healthcare solution, he or she needs to make sure that there are no intellectual property infringements, rights infringements, like, for example, copyright or patent. Those threats of being sued may happen. Like, for example, we mentioned before the 3D printed valve cases, who have replicated were being sued by the medtech company. I didn't follow further the case, but maybe the healthcare company, as far as I understood, realized that the exceptional circumstances were quite exceptional, so they let the case out of their threat of sue makers. But still, it's really important that makers are aware that these things need to be taken into account to avoid any risk, also with respect to being sued for third parties for intellectual property rights infringements. Finally, we wanted to raise the attention on other considerations. And our first recommendation here is check local laws and remember global reach. What does it mean? Extraordinary circumstances that we are facing due to the pandemic may have led institutional bodies to give new guidance or to set new national law having possible waivers to strict legal requirements. So with regards to guidance, I'm referring, for example, to the European Commission guidance that has provided so far, also with respect to 3D printing and which is also being called as additive manufacturing. And for example, possible waivers here are the Italian cases that I mentioned before, but also in the Netherlands we assisted to similar waivers. So we believe, I think that makers, when they engage in replicating healthcare solutions, they should regularly check for updates on the applicable legislation, guidance, and new waivers, new possible waivers. One example of possible waivers, again, I'm taking the Italian example because I'm Italian speaker, and also I studied in Italy, so it's easier for me to pick these examples. But in March, the legislation for tackling COVID-19 set also specific waivers, for example, for surgical masks, and especially for the simplification of market access of those surgical masks. So there is a simplified evaluation to be carried out by the Italian Institute of Health, the Istituto Superiore di Sanità, to permit the use of surgical masks free of CE mark. And another similar simplification has been put forward for personal protective equipment masks to be used by workers, which are subject to personal protective equipment regulation, and they are subject to the oversight of another authority, which is different from the Istituto Superiore di Sanità, which is INAIL. And again, they issued some simplifications. Also, another thing that I really wanted deem important to bring up to the attention here is the fact that perhaps there are not new waivers, but for example, there are also other kinds of waivers within the law itself. Like, for example, I've been asked also sometimes to explain a little bit more the so-called, in Italy again, uso compassionevole, because which is not a new waiver, because it was foreseen by the Article 14 of the law implementing medical devices legislation, and which again sets some possibility to request an authorization to use compassionate medical device for which conformity assessment procedures of medical device have not been completed for the treatment of individual patients for compassionate purposes in exceptional cases of necessity and urgency. This is a very difficult topic again, but I think it's also worth to be considered as such in every national legislation, and to see also national guidance with respect to these kind of waivers that might apply in their circumstances. And the second point that I wanted to bring up to the attention is to remember global reach. And by this, I mean that collaborative platforms such as careables.org have a global reach. So makers should evaluate the applicability of other local laws when they co-create or replicate solutions. So in addition to the laws where the maker is established, they should also evaluate the applicability of other states. Like, for example, if other collaborators that are designing something are in another state, that law as well might be worthy to be taken into account. Or, for example, if you are designing something and you are planning to put the object into the market, or you want to give it to another subject in another state, again, you should be aware that also law of that specific place may be relevant. So I would like to conclude with provocative questions, since the legal framework here needs new rules. Maybe it's time for new and clear rules for makers and designers and subjects at EU and national level. My answer is stay tuned. We are going to draft a paper later this year concerning recommendations to policymakers for careables.org, and it will concern open source hardware care as well, and 3D printing. So we are very much looking forward to give also recommendation, not just to makers, but also to policymakers. So thank you very much for your attention.
So Elisabetta explained very well the complexity of the topic, and laws is always catching up with what's going on. So it's important to use what's happening also as a case study to explain that some topics are treated globally, not locally. And I think that's when she was talking about the difference between thinking local and acting global, that's one of the key points. So to actually be able to do this, the role of community is fundamental. And if you have been part of some groups or been interested in what's going on in the maker movement in this period, for sure you know OSMS, that it's our last guest. We interviewed Sabrina Merlo, local response lead for OSMS. But today with us, there's also Christina Cole, and she is the documentation lead, so the one maintaining the medical supply guide, the huge document collecting all the project and explaining and translating this documentation for makers. So we'll see the interview to Sabrina now. but also we'll have the chance after during the Q&A to speak with Christina as well about the project or how they structure the projects.
Well, I'm happy to join you to share a little bit of this story of 9 weeks at Open Source Medical Supplies. I think we're just past 9 weeks old. Open Source Medical Supplies, as many of you know, is a Facebook group. It's just a public forum for makers, crafters, manufacturers to share information about open source designs for medical supplies and other strategies dealing with the coronavirus pandemic. You know, it's designed for people to share information, to pool resources, to connect with collaborators, fundamentally the definition of an online forum. It was started by this friend of mine, Guy Cavalcanti, the guy in the Navy jumpsuit, who I know from my 10 years at Maker Faire. I was at Maker Faire from 2010 until June of 2019. And so we worked together on some of his projects. One is this entertainment giant robot fighting project called Megabots that he was involved with, and we did some shows together. But also I worked with Guy when he was doing some series of early talks around how to make a makerspace, because he's the founder of Artisans Asylum, one of the largest makerspaces in the United States, which is just outside of Boston. He also, though, most recently has been the CEO and founder of something called Breeze Automation, currently an R&D soft robotics startup in San Francisco. But in about early March, he started to have difficulty continuing operations. He was not able to get supplies for the robotics company, and started to pivot his attention to what was happening with the breakdown of the supply chain from China as China went into shutdown. You know, news evolving, Guy watching, Italy goes into the nationwide lockdown on March 9th. And then on March 10th, Guy created the Facebook group. Open source. Well, actually the original name of the group was Open Source Ventilator Project on March 10th, because that was really probably the initial spurt of sort of maker interest was focused on this question of our limited ventilator supply in the wake of an explosion of the virus. But in some conversations with his community of medical folks, surgeons and friends, over this 24 hours, Guy realized that the issue was not ventilators. The issue was protecting the people who have been trained for years and years, who might actually be the ones administering the ventilators. That PPE and other supplies were probably a bigger issue, which is why he changed the name to Open Source COVID-19 Medical Supplies. Initially, I think, you know, of course, like any Facebook group, it's a manifestation of the founder's personal network. And I think Guy's background crossed a lot of disciplines and communities, and that was the initial sort of seed for the group. But that with the zeitgeist, this group exploded in 1 week. There were 12,000 members. I joined somewhere in the first few days there as part of, you know, his extended network. But very quickly, it clearly tapped into a vein. And a back channel started in Slack. This was a post from one of the people wrangling Facebook. She was talking about how quickly the following was building. And I think part of this is this cultural leaning from the maker community. and potentially Guy's community, if you want to use that as an extension, towards duocracy. It's an organizational structure in which individuals choose roles and tasks for themselves and execute them. I mean, this is a community that has a great sense of initiative and purpose. I'd say it's a generous culture, and the idea of being able to contribute something was hugely motivating. So again, Slack was a big tool we used. This is where we are at Slack today with 823 people in the open source COVID-19 Slack. The idea of the Slack channel is not to produce designs. This is to manage the information around the designs that we're seeing, as well as the connective tissue and representation of local response groups around the world. Also a function for communication across the Facebook moderator team. And the group is just like a forum any maker forum that you might see. People sharing images of projects they're developing and asking a lot of questions. Lots of extended responses and exchange. Highly productive and really serving innovation in a kind of rapid format. So 8 days into the organization, the version 1.0 of the medical supply guide was launched. This was basically the work of a team of medical folks working with engineers to review and assemble what they thought were the best designs emerging from the Facebook community. So this was before we had any hospitals committing to accepting open source supplies and locally produced designs. And so I believe this group took quite a risk to actually try to clarify and curate a list of designs that appeared to be to serve the medical community's needs and the social services community needs by a team of reviewers. 19th of March, so the next day, we started seeing press around Christian Fricassi and team's Venturi valve, which, just to give you a sense of the time frame of this. Again, super galvanizing story for the global maker community. And in 2 weeks, this Facebook group had 49,000 members. This is a private Facebook group, so you can't just, unless you answer all of the questions satisfactorily, you don't get automatically added. So there's a percentage of these folks that are manually reviewed and accepted or declined. Plenty of bots were declined in the creating of this group. And the frenzy of information was coming in like a fire hose. This is a post from one of the main moderators, or became a moderator. She was talking about posts coming in every 1 to 2 minutes. And this was a discussion about implementing posting approval. But the challenge, initially the group was an open post, so anybody could post whatever they wanted. And we were seeing this amount of noise and the quality of information declining. So on about March 20th, we chose to turn on the Facebook moderation and really take on the curated forum. So this, this was a turning point for us. Again, this is only, whatever, that's 10 days basically into the project. More back channel conversation. Guy, this is not a phenomenon or a project that anyone really expected to dive so deeply into. Again, the zeitgeist, Hillary Clinton. We know her as the last Democratic presidential candidate, posting about the lack of PPE in our hospitals. And about this time, makers are really turning on the production lines, whether it was themselves in their homes or in their garages. But we were seeing in the forum a lot of chaos around makers with 10 face shields calling up their local hospital to see if they could donate or what they could use or could they approve their design. And so there was a decision to really put some energy into a local response guide, which I was quite involved in, really as a best practices guide for local teams and individuals working to produce and distribute open source PPE and medical devices. The idea was to try to help people with strategies to pool resources, to scale production, and to really continue to be a major asset to the medical community instead of an annoyance. At about the same time, at 3 weeks in, we did our first, Guy did a poll where he asked people to share a tally of what they had produced, images, where they are, what they made. And I think over 500 post responses later, we ended up with this count of 238,000 items. Again, this is a Facebook algorithm. This is a tip of the iceberg picture of what is being produced worldwide. This is a dominant, U.S. forum. So this is just a snapshot of what I call the tip of the iceberg. And in 3 weeks, we were at 62,000 group members. At 3 weeks also, we were able to secure some funding for the organization, actually, and succeeded in transitioning to an organization at 3 weeks, where we had a fiscal sponsor for a nonprofit, and we started to actually do the work of articulating who we were as an organization and what our goals were. Our program focus, open source authority, constantly evaluating and propagating best practices, designs, and standards as they evolve with vetted information sources and secure systems. An ecosystem nexus, connecting with relevant communities, for example, hospital systems in need, fabrication groups, design groups, philanthropy, and partnering for effective coordination of a global ecosystem. And third, local response blueprints, helping stand up local chapters and distribute responses throughout communities around the globe. This included support in community building, communication strategy, organization. At 4 weeks in, a YouTuber, maker, influencer, US author released a video that went quite viral on how to help your hospital. This is an effort, a local response effort in Alabama. And this team, this is an incredible documentary of the kind of distributed manufacturing that was, haven't seen a better, but the organizational approach towards these local response maker missions, initiatives are. So if you haven't seen this video, I recommend checking it out. It's a portrait. At 6 weeks, we were working with a lead who had access to a large pool of translators. So at this point, there's 400 plus translators working on 54 languages to translate the medical supply guide as well as the local response guide. But not just to translate. Actually, the bigger goal is to localize the information. So to collaborate with medical professionals as well as makers and manufacturers in these regions to make the information relevant to those local communities. Quite a project, as you can imagine. And then at 8 weeks, we saw some, here's the production. So we started doing this weekly tally and count every week. This is the look at 8 weeks. And we heard that Lithuania had reached self-sufficiency. I will say that actually this group in Alabama was the first time I heard of a local response network satisfying a region's PPE needs. And this was the second with Lithuania reporting. I also wanted just to share with you a picture of what we covered in the topics of the medical supply guide. This is recent, the most recent issue. And these are the open source designs categories that we have in the medical supply guide. So everything from goggles to shoe covers to nasal catheters, oxygen masks, hospital beds, ventilator machines, but also, humidifiers, pulse oximeters. It's quite a range. And at 9 weeks, we have stabilized out at 73,000 members in the group. We have people leaving and people joining at a rate that is sort of stabilizing the group capacity. I think engagement is reflecting to some extent the PPE and the sort of stabilization we're hearing about. That given the success of most of these shelter-in-place initiatives, that we have to some extent flattened the curve of the virus, and we're seeing some news pop up on my screen, and that's reflected, I think, too, in the output that makers are seeing. You can see there's a dip here in the reporting. Again, the tip of the iceberg reporting, but you can see that week 6 there of the count, which was actually week 8 of open source medical supplies, was the peak. And then the week ending May 8th, we saw a decline a bit. 10 weeks, we're in 10 weeks. I think conversations are starting to happen in the forum about what it means to re-enter from lockdown. So conversation, for example, took off yesterday in the forum around how a community college, a large community college in Florida, might do planning around how much PPE and things like hand sanitizers they would need to operate safely. So how do you make that projection as an entity or an institution based like on per capita numbers? Like those kinds of questions. Again, there's not tremendous information out there that we are hearing from a top-down authority. So a lot of this information, again, is local, and intelligence is distributed and requires crowdsourcing for us to get ahead of this best we can. We're also doing some coalition work and ecosystem mapping of this whole local response, trying to get a great global picture. We're working with the Fab Foundation, Tikkun Olam Makers, and Nation of Makers in the US. We're having a conversation this week in the OSMS local response community on scaling with manufacturers and some of the experiences and case studies we've seen of makers and makerspaces operating almost as prototypers, and then local manufacturers, prototypers and community organizers, building the relationships with the hospitals, coming up with the design that was approved, and then engaging with local manufacturers to move to things like injection molding and die cutting to actually scale production. I think those relationships, those collaborations are new, and we're going to have a conversation about what that's been like. Guy is doing a keynote at this weekend's 24-hour virtual Maker Fair. And we're in big work transition, trying to finally move the design library and the local response resources online to a website with a better user experience. Emerging issues and questions and things we're thinking about are, as certain regions calm down, where is there the best information about hotspot monitoring as things emerge, and how will makers pivot if their local needs are satisfied? Are there mechanisms for distribution to areas, just not just efforts, but distribution efforts, but also like where are the resources as well for helping other communities that are in need? And also, I think a big question from an organizer point of view, like myself, someone who's been working in the maker community for a long time, I'm very interested in what policies we might articulate that really can support and recognize this distributed manufacturing effort that really has contributed a lot, has saved lives in this situation. How are we conceiving of these networks of makerspaces, fab labs, and individuals universities as an emergency response, almost a national security asset. So I think these things will take up some thinking and some work in the near future. And then again, you know, it's only 9 weeks in, so that should give you a little bit of a picture of the experience at Open Source Medical Supplies. And I'm looking forward to having some conversation with folks in the audience.
So that was another very fascinating discussion to see how communities can react globally, and as people are helping to coordinate, but then locally they can really tap in and talk to the healthcare professionals and bring things directly where they're needed. So we can open now a Q&A session, and we have our guests live to answer to the question that we will receive through Facebook and LinkedIn. I don't know if all our guests are here. Welcome, everybody. Thank you for joining. Thank you so much. So Sabrina Merlo and Christina Cole from OSMS, Dr. Rhys, Benjamin Rhys from the Intubation Box Project, Elisabeth Biazin, and her colleague Eric Kamenjazovic, I'm sorry for the pronunciation, from KU Leuven. Thank you so much. So we can see if we got questions. So first one from for Dr. Rhys. Can you see?
Yeah, absolutely. So, I mean, it's a pretty good question. At least in emergency medicine, we already have a triage system in place, you know, to look at the level of acuity of the patient coming into the hospital. I think that even though we always had infectious diseases in mind with the way we did things, our workflow has changed. You know, and in every hospital, at least in the United States right now, you walk into the front door, somebody is already there screening you, putting a mask on you. Before you can even get to the front desk to ask where you're going, to get into triage if you're coming into the emergency department, things like that. And you know, it's funny, a lot of these hospital networks had a lot of people whose jobs were actually kind of furloughed for a while, who now those people are going to be having to form completely new workflows, completely new protocols for the way that we just normally have people in and out of the hospital. This was a really big wake-up call for honestly things that we already knew. We already knew how viruses work. We knew how transmissions work, but I think we had all gotten a lot too comfortable and a little too lazy with the way that we were going about things. And so this is, I mean, there's very little silver linings to the COVID effort, but at least this has woken up a lot of people to the way that we need to really be paying attention to our infectious control.
I'd like to ask you an extra thing connected to this. Do you think it will change also the perception of the maker movement within the health and care sector?
Absolutely. I mean, not just for me personally, and just seeing people coming out of the woodwork to help and provide things, but I mean, without the maker community, thousands of other lives would have been at risk because we didn't have just the basic things that we as healthcare providers, you know, especially the ones on the front lines, it's not really in our head actively, do I have enough masks? Do I have enough this? You know, when I've gone and done medical work down in the third world and things like that, like, okay, you have to kind of MacGyver things, but never really in our minds do we think, I have to be MacGyver and come up with things in these first world hospitals, or what we would at least like to believe are first world hospitals. And the maker community has just stepped right up and made a lot of difference that I don't think would have happened otherwise if it wasn't for that community.
Thank you very much. Any other question? So I would say this is for the legal team, Eric or Elisabetta.
Hello, can you hear me?
Hi.
Hi.
Yes, perfectly.
Okay. Yes, I think it's a very interesting question. Could start changing the regulation we got at the moment? Yes, I think this this process we are living now will imply for sure starting at the policy making level concerning new regulation on open source hardware in healthcare. And we are witnessing at the moment at certain discussions already. For example, the fact that a recent report by the European Parliament from the think tank STOA refer that, for example, 3D printing and open source hardware is one of the key technologies to fight COVID pandemic. So I think now policy at the EU policy making, this is quite clear that it's an important topic to tackle and to reflect upon certain facts in particular concerning IPR, meaning intellectual property rights, and also concerning liability for makers, for designers, and also concerning the use of collaborative platforms online where you can share certain designs. I don't know. Eric, would you like to add something with respect to this question?
But maybe I would just like to add medical devices legislation as well could be influenced by this pandemic, and then maybe in a way pandemic could have an impact on the regulation in the future. But yeah, apart from this fields of law, I'm not sure about the others. But here the change will be visible in one way or the other.
I'm interested to ask you, out of all the things that are regulated by the medical device law, what do you think is the aspect that slows down innovation, or the maker approach the most?
I'm not sure I have an answer to that right now. Elisabetta, do you have an idea?
So I would like to bring some ideas as a reflection in light of the experience we had, because the research we outlined so far comes from the careables.org project, which is an Horizon 2020 project funded by the European Commission. And as anticipated before, we have been researching with a network, an amazing network of partners, and also all the challenges, and we have seen all the challenges that makers are currently facing at the moment. I have the impression that it's for makers and designers, but especially for makers, the gathering in Fab Labs, it's a kind of reality that it's between some kind of definition provided by the law. So I think more clarity should be provided at EU level guidance or national guidance in this regard. We have focused our research on intellectual property, liability, ethics and data protection, and we found that in some cases it's not clear to what degree, for example, makers are liable, and it's really complicated because, of course, as explained before, the global reach of, for example, collaborative platforms may imply different regulation, etc. So I think these more or less are the challenges And as said before, stay tuned because we are going to provide our recommendation for policymakers later this year with respect to EU law, especially because we are based in the EU and we have more familiarity with EU.
Cool. Thank you very much. Any other question? I think this could go to Sabrina. I know that you worked a lot, even recently, about this topic.
Well, we do have a number of, I think I can't answer this question about supply chain locally, like in Mexico. I'm in the United States, but this has been a recurring issue all over the place in terms of both with the overall global supply chain breakdown, in addition to certain supplies becoming heavily in demand. Makers are having to innovate not just because of the virus, but also because of lack of materials in certain regards. Like all of a sudden, there's no elastic, and you need to change the designs because there's no elastic. I think that this is where the network and the grassroots organizing and person-to-person exchange is better than any algorithm at this point. That local organizing is key. In our local response network, there I think are 7 local response groups in Mexico organizing. So you can find that list if you go to opensourcemedicalsupplies.org. And my recommendation to Manuel would be to make sure that he is in all of those forums, local forums, and communicating locally. One of the strategies here has been, in the US, it's been successful, is some of the groups pooling their needs and getting larger, looking at larger quantities of orders of materials. But I do think it's like an intelligence effort to try to figure out either whether there's a better design or there's ways that people know of supplies that aren't sort of visible in, at first glance.
And I can add to that. We had an issue pretty early on where the acrylic that we were using for the boxes, we had 3 or 4 days where we were starting to get up and running, starting to make orders. And all of the local grocery stores and whatnot decided we need to use this acrylic to put in front of our cashiers. And all of a sudden we had 0 supply of acrylic almost overnight. And just like Sabrina said, it ended up being network. We had people who had acrylic that was just sitting in their garage that saw our thing and just showed up and donated the acrylic sheets. At the same time, I personally reached out to some manufacturers and I'm like, look, I can't offer you more than what these massive global, chains are offering you to buy up all your acrylic, but this is why I need it. And not to downplay the reason they need it, but if you can at least give us some of it and not sell all of it at a massive profit to these people. And we had actually some really good responses and we were able to get the supplies we needed.
Yeah, and we've had some examples too where big corporations like Coca-Cola have come into play when they can deliver a large amount. So again, that's networks though. That's an individual who has access to executives who organize that, and but it's a tough situation. It's part of this. It's a part of the problem.
Well, I'd like to add on this. So it's definitely the personal network, as Sabrina, you were saying before. But I also think it's important to don't speak only for single labs or even worse, single makers. But when you are representing a community of tens of thousands of people, then of course your voice gets on higher levels. So I think that's why it's important also to be part of a community. Maybe another couple of questions. Let's see.
I think this is another for the ethical legal team for K11.
I'd like also to hear from Christina, because
Okay.
no, from both of you. I mean, there are two aspects. One is the legal one, and the other one is the technical production one. So, Elisabetta, if you want to start.
Yeah, so I will be very brief. So the question is, how can quality control, for example, for 3D printed vaults, be organized in such a large and fragmented scale? And who should coordinate and be responsible for this process? I think it's a very interesting question. And if we are talking, for example, about 3D printed vaults, as introduced before, it might be, as indicated by the European Commission, that we are talking about medical devices. At the moment, medical devices are regulated national-wise. And there has been a new regulation in the EU. I'm speaking about the EU because it's the law that I know. There is a new regulation that will be applied directly within 1 year. It has been postponed recently, the application of certain rules. So at the moment, there are national rules for medical devices, which means that every national member state has its own control with different authorities surveilling these processes. Whereas with the new regulation, there will be a different setting. But indeed, it's a fragmented scale, in meaning that there are different member states that have overview on the specific national situation, and then makes sense because every national state has its own legislation. Yeah, this is my let's say short opinion on this. Eric, would you like to add something, or do you have an? Okay,
I can add a little bit here as well. Just that it varies not only from country to country, but city to city, region to region. That presents a very unique challenge. One thing that we have seen kind of touches back to what Sabrina had said, that it can be very, very local. So we have seen clinicians or hospitals in contact with maker spaces saying, I need face shields. And then it almost as if the hospital will then try them and give feedback, and then the makerspace will produce another version. So it ends up kind of going through this prototype process where the end project is something that the hospital will then say, okay, this is the one, this is what we want you to make. And then we incorporate that design because it has kind of undergone that unofficial, unregulated, very specific to that local region prototyping process, and then versions of that particular product afterwards. So it's been really interesting to watch that process because we haven't experienced anything like this before. Normally, this is an area that is extremely regulated, and some of that does seem to go out the window during a crisis.
Thank you very much. Thank you both. Maybe a last question.
Okay, from Julia, how do you envision the relationship between your organization and the healthcare sector to be after this crisis? That's a great question. That's part of why we had a shift in name from open source COVID medical supplies to open source medical supplies, because we are hoping that after the crisis is over, after some of these PPE or supply demands have been met, we are hoping that healthcare organizations, hospitals, doctors, or just kind of larger organizations realize that a lot of the things that they use and the things that they need are very vulnerable to these supply chain interruptions. We've learned a very hard lesson here with this crisis. We want them to realize that many of these things don't need to come from far away, from massive corporations. Some of these things can very easily and readily be produced on a local scale, whether it's within a city, region, or a country. So everyone understands, or seems to be very well understood, that healthcare in America is very expensive and difficult and complicated. And we are really hoping that this at least changes a very small part of that, in that these supplies, these devices, these even community items that we have do not have to be so expensive, so difficult to get, and so vulnerable to these supply chain interruptions.
Well, that was very, very interesting to have you all here. This conversation could go on much longer than this, but we already exceeded the time. And I really want to thank you all. So thanks, Eric, Elisabetta, Sabrina, Benjamin, and Christina. Your contribution was really, really useful to all of us. And I'm sure that what we've seen during this week will have a huge impact in the future. So if someone still have questions, we can follow up on comments on YouTube, Facebook, and LinkedIn. And we recorded the interviews in a longer format. We decided to have a shorter selection for this webinar, but the videos will be available on YouTube. So we'll share the links, and we are happy if you want to reach out for other questions and comments. So thank you, everyone. Thank you very much. And I hope to see you during the next events that we will organize. Goodbye.